All right, let's jump right into the clinical material. Welcome to this explainer. This is an intensive, high-yield diagnostic simulation, and it's specifically built for those of you gunning for that elite 270-plus board score. We are completely stripping away the fluff today. No basics you already know. We are focusing purely on strict, peer-to-peer clinical reasoning. In this session, we're going to master the intricate mechanisms, the exact management steps, and the classic diagnostic traps across two really heavy-hitting modules, knee ligamentous kinetics and microcytic anemias. We're going to be relying heavily on absolute visual data and strict option matrices to get us there. So let's just get started. We're going to begin with mechanical stress to the knee. Specifically, we need to analyze the rotational shear that causes an anterior cruciate ligament, or ACL, tear. Now, the mechanical triggers here are absolutely strict. We are looking at sudden deceleration, aggressive hyperextension, or a severe non-contact rotational pivot. Think about it. When you see an athlete planting their foot and just rapidly changing direction, that massive kinetic force generates a profound rotational shear. The ligament simply cannot withstand that kind of torque, and that leads to an acute rupture. Now, notice the stark contrast in vascular kinetics between the ACL and the meniscus. This right here is exactly how you strictly differentiate these injuries clinically. The ACL is a highly vascularized structure, so when it tears, you get instant vascular disruption. That drives a rapid, massive hemorrhosis. The knee literally balloons up within an hour or two. Conversely, the meniscus is largely avascular tissue. If an athlete tears a meniscus, you just won't see that immediate blood filling the joint space. Instead, what you get is an insidious, delayed effusion that slowly evolves over the next 12 to 24 hours. So this vascular variance directly builds our physical exam. For that highly vascular, highly sheared ACL tear, diagnostic confirmation clinically requires a positive Latchman test and the anterior drawer test, which perfectly demonstrates that anterior knee laxity. Now, let's contrast this immediately with the posterior cruciate ligament, or PCL. The PCL mandates a completely different mechanism. It requires a direct posterior-directed force on a flexed knee. Think of the classic dashboard impact in a motor vehicle accident. The defining clinical presentation you're looking for here is the posterior sag sign. Okay, moving off the ligaments and onto the cartilage, let's detail meniscal tears. The mechanism here is what we call the cartilage grind. This is driven strictly by twisting injuries on a planted foot. When you're examining this patient, you need to identify joint line tenderness, but your definitive exam maneuver is going to be a positive McMurray test. When you perform the McMurray, you are feeling for a palpable catching or clicking sensation. That's the torn avascular cartilage fragment literally grinding within the joint space. The patient will also likely report mechanical locking of the knee. And this brilliantly illustrates how test makers are going to try to trick you. Welcome to the clinical variance box. Both an ACL tear and a meniscal tear will present with a patient reporting a loud pop followed by obvious knee instability. So how do you actually isolate the pathology? You have to look strictly at the timeline of the joint effusion. The variance is absolute here. The ACL tear presents with massive immediate swelling, a hemorrhosis within just a couple of hours. The meniscal tear features an insidious, delayed effusion presenting the following day, which is uniquely marked by that mechanical locking we just talked about. Let's put this right to the test with an integrated assessment. A 22-year-old athlete felt a pop during a cutting maneuver, and they present just 1 hour later with a massively swollen knee. So, what is the definitive next step in management? Based on our breakdown, the cutting maneuver, the pop, and crucially that massive swelling at the strict 1 hour mark isolates an ACL tear with hemorrhosis. So let's look at the option matrix and systematically dismantle the incorrect options here. Option A, an X-ray. Well, that's first line if we suspected a fracture based on the Ottawa knee rules, right? But it won't definitively assess a soft tissue ligament tear. Option B, arthrocentesis. This is absolutely mandatory if we suspected a septic joint with a high white count or maybe a crystalline arthropathy like gout, but it is not the next step for acute trauma with hemorrhosis. Now, option D, conservative management. This is appropriate for mild osteoarthritis or patellofemoral pain syndrome, but it's completely inadequate for a massive acute hemorrhosis in a young athlete. And option E, diagnostic arthroscopy. It's just too invasive and is no longer the standard first diagnostic step, so this leaves us with option C. An MRI is the strictly required modality here. It definitively confirms the ACL tear and it rules out concurrent injuries, like medial meniscal tears, serving as your absolute roadmap for definitive surgical planning. Excellent. All right, let's execute a really rapid transition into our second clinical module, microcytic anemias and hemoglobin electrophoresis. We are shifting directly from orthopedic mechanics over to hematologic pathology. Let's get into it. We'll start by analyzing the absolute kinetics of iron depletion in iron deficiency anemia, or IDA. Think of iron as the fundamental building block of heme. When severe iron depletion occurs, and this could be from GI bleeding, menorrhagia, or malabsorption, it fundamentally halts hemoglobin synthesis. And the earliest, most specific indicator that these iron stores are collapsing, it's a drop in serum ferritin. Long before the anemia becomes clinically profound, that ferritin level plummets. Let's actually visually confirm this pathology. Look really closely at this peripheral blood smear. You can clearly see the classic microcytic and hyperchromic cellular architecture. The red blood cells are small, that is your microcytosis, and they have these enlarged areas of central pallor, that's your hypochromia. This is the exact visual signature of impaired hemoglobin synthesis. Notice those empty little rings? They simply lack the iron required to build hemoglobin. Now, when you're evaluating the CBC parameters for IDA, you immediately look for the hallmark microcytic anemia with an MCV of less than 80. But the absolutely crucial pairing here is the elevated red cell distribution width, the RDW. Why does this happen? Well, as the bone marrow is progressively starved of iron resources, its production becomes frantic and uncoordinated. It starts pumping out increasingly smaller, unequal cells over time, and a high variance in cell size means an elevated RDW. Now, contrast that dynamic with the genetic deficit of beta thalassemia minor. In this condition, the systemic iron stores are completely normal or sometimes even elevated. The microcytosis here isn't driven by a lack of raw materials. It's driven by a defect in the factory itself, specifically a genetic defect in beta-globin chain production. So, the crucial point you have to remember is how this genetic defect alters the CBC parameters compared to simple iron deficiency. Here is the thalassemia signature. First, the RDW is strictly normal. Because the defect is genetic and constant, the cells produced are uniformly small. They aren't varying in size. Second, you see a paradoxically elevated red blood cell count. The marrow realizes there is an anemia and aggressively compensates by just pumping out more and more of these tiny defective cells. Finally, the definitive diagnostic signature is found on hemoglobin electrophoresis, demonstrating an elevated HbA2 greater than 3.5%. Let's deploy another clinical variance box to structurally isolate these conditions. Both present identically at first glance, an MCV less than 80, and target cells on a smear. But their systemic markers diverge entirely. IDA features an elevated RDW, a low RBC count, and a severely depressed ferritin. Thalassemia trait features a normal RDW, an elevated RBC count, and normal or high ferritin. A phenomenal quick calculation here is the Menser index. That's just the MCV divided by the RBC count. An index of less than 13 strongly suggests thalassemia, strictly due to that paradoxically high RBC count. Time for our final integrated assessment. Let's look at this vignette. An asymptomatic 28-year-old female presents with an MCV of 68, an RDW of 12%, which is normal, by the way, an RBC count of 5.8 million, and a completely normal ferritin level. What is the most appropriate next step? Look at the data carefully. Microcytosis, normal RDW, elevated RBC, normal iron stores. The Menser index here is 68 divided by 5.8, which is well under 13. This is absolutely not iron deficiency. So let's rigorously evaluate the option matrix for this. Option A, oral iron sulfate. This is a classic trap. Prescribing empirical oral iron to a patient who has normal ferritin and thalassemia trait does absolutely nothing but risk iron overload. Do not fall for it. Option C, a bone marrow biopsy. This is an incredibly invasive and completely inappropriate test for an asymptomatic microcytic anemia. Option D, intramuscular vitamin B12. Well, that treats a macrocytic anemia, not a microcytic one, so that's out. And what about option E, a blood transfusion? Completely unwarranted for an asymptomatic patient with mild baseline anemia from a trait. Therefore, option B, hemoglobin electrophoresis, is the strictly required test here to confirm the elevated HbA2 and definitively diagnose beta thalassemia minor. As we wrap up this explainer, I want to leave you with a final provocative thought. What singular systemic variable dictates your next clinical intervention when the initial presentations are indistinguishable? Whether it's strictly observing the timeline of a joint effusion to separate an ACL from a meniscal tear, or tracking the RDW and ferritin levels to diverge identical microcytic anemias, diagnostic perfection requires you to isolate those discrete clinical markers. Master the variance, and you master the diagnosis. Thanks for focusing in with me today. Keep studying, stay structured, and I'll see you in the next explainer.